Welcome everyone to the Perth and Kinross Integration Joint Board meeting of the 21st of June 2023. I'm Bob Benson and I'm the chair of the Integration Joint Board, and we will now move to formal welcomes and apologies. Adam, can you update us please?
Yep, thanks Chair. We've actually had no formal apologies for the meeting this afternoon, so unless there's any in the room to offer up. Right, okay, thanks Ian.
Thanks very much indeed. Item 2, are there any declarations of interest with regard to today's agenda? Okay, thank you very much indeed. We'll now move to the minutes section, and we have the item 3.1, minute of meeting of the Perth and Kinross Integration Joint Board of the 29th of March for approval. Can we go through the document for any accuracies that people want to clarify? Okay, I take it that the board agrees the accuracy of the minute. Can we therefore move to approve the minute, and can I have a proposer and a seconder, please? Thank you, David. Martin, thank you, seconder. The minute is now approved. Item 3.2, minute of special meeting of the Perth and Kinross Integration Joint Board of the 30th of May for approval. Any question relating to the accuracy of the minute, please?
Oh, sorry, just a small thing. If you remember, you've been very helpful to put me down as in the meeting. Full stop. Well, I was only in the meeting for a small moment in time, I think. Yeah, I didn't. Yeah. I got locked out by the system. Artificial intelligence.
I now remember that. We'll make that amendment, Ian. We now move to formally approve that minute, and I require a proposer and a seconder. David, thank you. I need a seconder. Is there someone else got the hand up? Is that Beth Hamilton? Yes, it is. Okay, thank you, Beth. I now move to the item 4, action points update. Chief Officer.
Thank you very much. In terms of the actions that are on the paper today for the IJB, reference 131, just noting that the financial framework for the mental health and wellbeing strategy is now included within the what is now termed the whole system change programme for mental health and learning disabilities, and so it's recommended that that action is now complete in the sense that it will be brought forward within the programme and not separately. And reference 141, which is to hold a development session on the carer strategy, and that was completed on the 5th of May, and the carer strategy itself is on the agenda today. Thank you.
Thank you very much indeed. I'm really sorry that I missed that session actually, but I hope people had an enjoyable session. Thank you. The next point is matter arising in relation to the Invergowrie medical practice. Chief Officer.
Thank you very much, Chair. In relation to the an update on the Invergownie medical practice, it's a formal update on the following the NHS Tayside Board meeting on the 1st of June 2023, which considered a report by the Chief Officer of Do I need to start again? I'm sorry.
Thank you if you could. Thank you.
Hopefully I can do it more eloquently this time. Yeah, happy to Chair to give an update on Invergownie medical practice, and following the special meeting of the IJB on the 30th of May, NHS Tayside Board met on the 1st of June 2023 to consider a report by the Chief Officer of Angus IJB, who is the lead partner for primary care services, and NHS Tayside Board agreed to support the recommendation to disperse the majority of patients to Ancram Medical Practice and the remaining patients to a small number of practices close by to where they live. And that has come into effect from Monday the 19th of June. And also, by way of an update to the IJB, as Chief Officer, I've been liaising with Gail Smith as lead partner in relation to a lessons learned exercise. And this is to be convened with a series of areas to be considered and agreement on that being reached at the moment. So that will follow in due course. And one of the key areas that will be considered is clarity on the role and remit of lead partner for primary care services, what is and what is not delegated to the IJBs and their role in giving direction to NHS Tayside and how that would be executed. So those are key areas I think that were under discussion at our special meeting. And also, we've had positive engagement that has commenced with primary care services in relation to completing a strategic health needs assessment for the Cars of Gowrie. So that's currently ongoing. Thank you.
Any questions? Ian.
Thanks, Jackie, for the report. It's in relation to the situation in terms of accessibility of the transport issue and whether this lessons learned will include looking at the issue around public transport and the reality on the ground and to ensure that we can take that bit forward.
Thanks for the question, Ian, and seeking clarification around that. The lessons learned will, at my request, following our discussion, seek some learning around how options appraisals are carried out, how those equalities issues are raised, and how they're managed within the reporting arrangements and the detail that's required to follow from that.
Thank you very much indeed. Oh, sorry, Colin.
Thanks, Chair. I obviously was present at our special meeting, and I also watched the NHS board meeting online. And I would just one of the things which I think came through in both meetings was about logistical or HR issues in terms of providing cover being diverted into a discussion of clinical matters. So I would like the lessons learnt piece just to there wasn't very much discussion of clinical matters in the actual options appraisal, but then when other options were being discussed, it came up as a matter of concern. So I'd like just to make sure that that was covered in the lessons learned, please.
I think we're happy to do that, Jackie. I don't think you need to respond to that. I think that's in your options exercise. Thank you. Thanks very much, Colin. I'm now going to move on to delivering on our strategic objectives, and item 6.1, the Chief Officer is going to give us a verbal strategic update.
Thank you very much, Chair. In terms of this update, I would like to just cover 3 areas as a matter of update for IGB members. The first is around the improved performance around discharge without delay, and I'll come to that in a minute. The second relates to, in fact, if the slides are available, I'll just take that in turn if that's okay. So I'll move on to that. And it's very pleasing to provide the Integrated Joint Board with a brief update in relation to performance and delayed discharge to just up into the beginning of this week. And key highlights to note are that the whole system improvement work across the Health and Social Care Partnership is resulting in significant improvements. National benchmarking reports indicate that we have a delayed discharge rate which per 100,000 in our population, which is below the median for Scotland and continues to improve. And in the 4 weeks leading up to the 16th of June, Perth and Kinross had the highest reduction of delayed discharges nationally and has been in the top 3 for a month now. So that is really giving a clear indication and evidence of the progress that's being made. And we know that within Perth Royal Infirmary, acute delays have been down to single figures for most of the month of June so far, and that is giving better patient experience and ensuring flow across our whole systems. If we could just move on the slide, I just wanted to show you the data that we collate and report on. We collect data in this regard on a daily basis. It's monitored on a daily basis, but this shows you the information that we supply on a weekly basis to NHS Tayside Business Critical Gold meeting. So this is a snapshot of where we were in March 2023. In fact, it's the weekly report for the 27th of March, and you'll see that on the PRI site there that we've set ourselves a trajectory to come down from that red. It looks pink on there, but it's really red, down into the amber and green, and that for the period shown here, which I can't quite see where it starts. So it's 27th of February. So for that month, we were a variable performance, but it's still in red figures. And if you'd just like to move on and to show you where we are now to the 9th of June, that we've come right down into the single figures there and almost in the green level. So that is showing the daily and weekly data. And the bottom chart is acute delays in Nine Wells Hospital, which you'll see are consistently either 0, but they're always under 3. So I think that demonstrates the performance there. And I suppose the highlights are that we're working well in terms of the whole system approach, and that's having a positive impact on scheduled or planned care at the PRI site, continuing to see better patient flow from our acute sites as well as across the 4 community hospitals within Perth and Kinross. And I think just an opportunity to commend the work to you and commend the work of all staff across the partnership who are contributing to the successful improvements that we've been making there. Happy to take any questions on that in particular at this stage, Chair.
If you switch on. Jackie, how do we compare with other parts of Scotland?
Thank you. I think the update that I was providing to you was that we are performing better than the median for Scotland, and I think that's, in terms of our demographics and population, I think that's commendable. Thanks.
Any other questions in relation to this? Martin? Sorry, too busy cleaning up. So.
Thank you. It's a bit of a drama here, isn't it? I think in answer to your question, Martin, I don't think it's any singular thing. I think it's been a whole team approach, whole system approach that's involved work right across from medics within the hospital, the nursing staff, our hospital discharge team, involving our GPs as well, and the care home sector. So, and I know Evelyn's online, but Evelyn has been leading a multidisciplinary team and leading Silver Command meetings on a weekly basis to ensure that we are taking that whole system approach. So it's not one singular thing. I think it's the whole system approach that we've been taking that will sustain this and keep that trajectory going. Thank you.
Beth Hamilton.
Thank you. First of all, huge congratulations to all involved. Evelyn, well done working as well as we are. Just not wanting to be the least bit negative or cynical. Are we sure that we've learned lessons and we've identified what is the improvement and how we can sustain it going forward? Or do you think we will dip back again as pressures come on over winter? Not that I don't think you are, Evelyn. I just wanted to ask the obvious question. Thanks.
You want me to answer, Jackie?
Yeah, I'm happy for you to come in. But first of all, I would just like to say when we get down into small numbers like that, Beth, then we're going to see variation and it will look like significant variation, but we're into very small numbers now.
Yeah, I think, Beth, just to put it in context, the Discharge Without Delay programme monitors all the activity and is quite a large programme of work around improvement. And that looks at all of the sort of process work that we need to do, all of the new pathway work, etc. So there's a good foundation for maintaining the trajectory that we've got. But as Jackie says, there will be, inconsistencies in that at times, but we're on the way. We're just about to commence over the summer our winter planning again. So I think it's really important that we're now planning for winter, because obviously we always have to plan for winter surge in terms of where we're at. So we're beginning that planning early this year, as we did last year, just to see if we need to really maintain where we're at. So, but that will include winter surge and where we need to sort of prioritise where we need to be. So yeah, that's where we're at.
That's fantastic, Evelyn, thanks. And I know the complexity of the programme you've been doing, so it's really good to see it all coming together successfully. My only concern was, as I know we're looking at the audit of the sustainability of our third sector, so I know that's going to make us a bit more vulnerable in the winter, but I know we're looking at that in advance, so yeah. I'm very happy. Thank you.
Thanks, Ben.
A question from David.
Majority of discharges back to care homes work well. There is, however, ongoing issues with poor discharges, and they're happening on a weekly basis. There is work streams looking at that And I've been asked to flag up any concerns I know about to the hospital discharge team, but there is ongoing work streams, as I say, but there is concern, not just in P&K, but across Scotland, that there's still that issue.
Thank you very much, Steve, and thanks for that contribution, because discharges back to care homes for people who've come from care homes into hospital, but we're also still relying on a significant number of interim placements. So we're monitoring that very closely and very keen to ensure that we're learning lessons from some of those instances that don't work well. Thanks.
Have you now finished your update, Jackie, or do you want to continue?
Thank you. The second area that I would just like to provide an update on is that IJB members may have noted in the national news yesterday that Public Health Scotland published its 22-23 benchmarking report on progress with the implementation of the medication assisted treatment standards, otherwise known as the MAT standards across Scotland. And good progress has been noted over the last year overall, and Perth and Kinross is showing in terms of the focus on standards 1 to 5. 3 were rated as green and 2 were rated as amber. And over the next year, we will continue to embed all of the standards with support across all of our partners, statutory and third sector partners, along with people with lived experience. And I'm noting that we have a progress update on substance misuse services coming to the IJB's meeting in September, and we can provide an update, a detailed update at that point in time. But good progress for Perth and Kinross in that report. And the third area is really just to ensure that the IJB are cited on work that will be being taken forward over the summer in relation to consultation and engagement to underpin a review of our strategic commissioning plan. That will take place over July and August, and we will make sure that you're provided with communication and an opportunity to dip into or take part in a whole series of activity, roadshows, community groups, strategy groups and carers groups across Perth and Kinross, which will take place over July and August. And we'll make sure you're kept up to speed on the communication on that, and we will be bringing forward the reviewed strategic commissioning plan in due course for your consideration. Thank you.
Okay, Ian.
Thank you. Just a technical point. The assessments are in consultation over July and August is fraught with difficulties for those who are going or may go on holiday. And I'm wondering if you're going to leave at the end of August a slight variation to ensure that some organisations or someone personally wants to take a submission can do so. It's okay. I'll put my glasses on.
There we go. Sorry, I wasn't pressing it hard enough. Yeah, we will be evaluating and editing all the feedback that they have in August, but we are doing focus sessions as well to ensure that anybody that we haven't managed to capture during that broader consultation, that we do get to them as well. So I think we've covered all the bases in terms of ensuring that we don't miss people, because we are recognising that it's the summer holidays.
Thanks very much indeed, Jackie. I've been remiss in actually not welcoming Susie Flower, who's the Director of Nursing for Communities and non-voting member of the IJB. Welcome, Susie. And also, we're very familiar with your predecessor, Sarah Dickey. So we look forward to having your input. Thank you very much indeed. So I greatly welcome you here today.
Thank you, Chair. Thank you.
Okay then, thanks. Let's now move on to the Tayside Mental Health Services, Mental Health and Learning Disability Whole System Change Programme. Nice and brief title.
Thank you very much. I'm happy to introduce this report, which brings forward the complete whole system mental health and learning disabilities change programme for approval. This was a request from the last meeting of the IJB. The programme builds on the improvement plan, which was approved previously, and now includes 4 additional priorities for service redesign. And this will be the focus of the change programme for mental health and learning disability services across Tayside for the next few years. And it refines the whole range of work streams that were underway as under the Living Life Well strategy. So the development of the 4 additional work streams has been underpinned by a series of engagements and opportunities to comment and influence the content, and includes stakeholder representation on all of the work streams. Area will have an executive sponsor and workstream lead or leads, and will report progress to the programme board and the executive leadership group, and in advance of reporting to the 3 IJBs in Tayside. You'll see in the report that there has been an initial assessment of the requirement for additional capacity or funding to deliver on the programme, and that has been considered and will be discussed further as that's refined further, and will be part of the development of the financial framework. And for awareness of the IJB, NHS Tayside board at its last meeting agreed to schedule a workshop for all board members and members of the 3 IJBs on whole system data and performance in mental health services in Tayside, and it's likely to be held in September. There's 1 or 2 dates that have been highlighted for that, and I'm involved in planning the programme for that with the Director of Public Health and Executive Lead for Mental Health Services in Tayside, so you will receive an invitation to that in due course. The Angus, Dundee and Integration Joint Boards will be asked to approve this programme today as well, because all 3 IJBs are meeting today, interestingly enough, so they're all scheduled to meet today. So this is on the agenda for the other 2 Integration Joint Boards today. So you're asked to approve the Mental Health and Learning Disability Whole System Change Programme. Note the emerging partnership with the V&A in Dundee around design thinking and design processes in public services, and to note the initial assessment of the additional investment that is required to deliver on the programme at this stage. Thank you.
Okay, thank you. I have a question from Jackie Jensen.
The additional
Not yet, Jackie. We discussed that as an executive leadership group. Can you hear me all right?
This is on, that's why.
Oh. Okay. The additional funding that you mentioned and is in at 3.4 of 200k part funding for this year and 450 for next year hasn't been agreed yet. And can you give me a kind of timescale when that would be likely to be agreed? Is it likely to be agreed, and can we approve it without knowing that funding's in place?
What an interesting set of questions. So the executive leadership group considered a whole series of requests that have been made across the work streams, so that there was an initial assessment carried out of that in relation to that. it was decided that we needed to look at that a bit more closely to ensure that there was not duplication and to ensure that where that could be time limited, that was time limited to the appropriate time frame. So there's still work underway in relation to that, and I'm hopeful that we will be able to conclude that certainly by the end of the summer. But your last question is around how can you approve a plan without the resources to deliver on that? Because you're not being asked to approve the financial resources around it, it's the plan. And I think there are areas in this plan which are identified as areas for improvement, which could be taken forward. There are other areas which could be described as enablers, as it does in the report, which we should be doing anyway. But it's those areas of redesign that require people to focus, to have project support, and to be backfilled to be able to do it. So it's those areas that are likely to be at risk if the finances aren't there. So I suppose. The answer to your question would be that the plan is dependent on additional resource. The extent of that additional resource is yet to be identified.
Thank you. And as I say, we're still being asked to note the additional investment. I'll take Beth Hamilton and then Colin Stewart.
Thank you, Jackie. It's a really comprehensive plan and I very much welcome it. The one thing I was going to ask is one of the criticisms on living, learning, whatever well, is that the complexity and the detail involved was kind of making it difficult to take it forward. And we've now got 10 priorities. And whilst I have complete faith in you, I have heard from different people saying it looks quite complex. When you break it down, it's probably not as complex as it looks when you first read it. But have you got the confidence that this is not too complex again for us to actually make a difference?
I think any transformation's complex. I think the difficulty here is the interdependency across the areas of service redesign. So each is dependent on the other, and I think there's a bit more work to be done there and to ensure that we've got the scheduling of that right. There are all of those areas, as you suggest, outlined in the plan, but I think some of those will begin to fall off and we can focus in on what's the service transformation that we're trying to achieve.
Yeah.
And I think it would be also really helpful at the workshop that's planned in September to begin to look at some of that complexity and how we can iron that out and focus in on the key big hitters, if you like, in terms of what it is we need to change and when, and ensure that we're focusing all our energies in the right areas. Yeah.
Thanks, Jackie. I agree about the joint working across the system, and I think it's very welcome to note that all 3 IGBs are looking at this today at the same time. So thank you for that response.
Colin Stewart.
Thanks, Chair. Obviously, a huge amount of work has gone into this, and thanks, Jackie, to you and the thanks, Chief Officer, to you and all the people involved. One of the concerns I had, I think, when we were looking at the draft of this that was sent to the Scottish Government was the number of items that were falling together. For example, there are quite a lot of action points which are due by the end of June. So I just wondered what progress had been made on those. Specifically, I was interested in, because we minuted it at our last substantive meeting, the redesign of learning disability in terms of the physical environment at Strathmartin. But then moving forward, how will we monitor progress against these actions as a board and as indeed three boards?
Well, currently the programme team that are supporting this are preparing a quite a complex Gantt chart. And for those of you, I'm sure most people will know what a Gantt chart is, but that will set out the whole schedule and the timeline over a number of years for this, and set out the key milestones and deliverables in a way that we can see that over the period of time, because what you have here is something that was prepared that was easy to read. The progress will be reporting to the programme board, which is a wide range of stakeholders involved in the programme board, to the executive leadership group and directly on to the IJBs. So we will need to find a format in which we can provide that can be easily understood. So we've yet to develop that, but that will be prepared over the summer. We also know that across the 3 IJBs that they are keen to have mental health services and progress updates as standing items across the 3 IJBs. So we'll make sure that that's reported on a regular basis across the 3. And I note your request for information, but some of that is still to come forward and report over the summer and into the meetings in July. But we'll bring that forward in due course. Thanks.
Do you require a follow-up? Because that's fine. Thank you. And in any case, Jackie, you'll be regularly reporting on this issue at every meeting, so we should get more information at that point. I'm going to take David Illingworth, and I see Maureen, your hands up as well. David, first of all.
Yeah, thank you. First of all, it's great to see the big challenge of redesigning care broken down into small steps, and this won't happen overnight. It's a long-term strategy, and I think it's reassuring to see that strategy. In terms of one of the work streams, it's about engagement, staff engagement, and it just seems to be a six-month WE project. So how does that 6-month WE project fit into the big important part of keeping staff engagement up?
That's a really good question, David, because in each of the work streams we need to ensure that we've got sufficient staff engaged in that and that there's communication with staff. But the work that I'm meeting again with the particular officer within the VNA is going to hopefully they're developing a prototype to work with us on design thinking, which also includes a cultural element to that, which is about how do you show up and how do you behave to think differently and work with others to think differently. So that's quite exciting. So what the plan is that we will build that in across the areas of redesign, and that we will ensure that we'll have a whole range of staff at all levels involved in that. So I think that will be, although it's a very short-term thing, I think that will change the way in which people relate to each other and behave on across this whole programme. So I'm quite excited about that.
I do have Sheila McCullen. Sheila, I've given Maureen the nod. I'm conscious that Maureen wasn't able to participate in the last meeting because we moved the agenda, if that's okay. Maureen, I'll take you first and then back to Sheila.
Thank you for that. There's 2 or 3 things I'd like to raise. First of all, the time scale of the whole programme. By May 2026, we're going to be looking at the preferred option for the end of PFI contract on Carsview. I take it that we are working towards options in that in the meantime, and that, you know, and I would like to know what progress has actually been made, and if there is a register of NHS and council estates that are actually available for any changes that are made here.
Thank you very much. There is a whole programme of work around planning for the end of the contract, and that's being led by the well, it was the Director of Facilities, and he's now his post is being recruited to, but it is being led by the Director of Facilities. And there are deadlines that are now in this plan that went there the last time it came to the IGB, and that was as a direct consequence of some of the requests that came from IGB members and NHS side board to ensure that that was there, Maureen. And there is currently an interim report that will be considered from the people who are working on or leading on that work stream, so that's coming forward in due course. So all I can do is give you assurance that the work is being taken forward and that the whole range of options will be considered. But again, it's about any reconfiguration or change to inpatient services can only really happen when a whole range of other things are in place to allow that decision to be made. So it is all about the interrelatedness of the whole programme.
Jackie, you need to switch yours.
The stakeholder participation group that I'm a member of met with quite a few MSPs, including Shona Robinson and John Swinney, and we were saying that we actually needed a cash injection for care in the community, and they were very supportive of that. Like, you know, this is in addition to anything else that's been agreed. Because unless we can, you know, upscale the care in the community and have early, you know, intervention in that, then we're still going to be needing hospital beds. And at the moment, 73% of the mental health budget is used for inpatient services. That's scandalous, really. That's really bad, you know. So we have to shift the balance as quickly as possible, and to do that we need to put extra money into the community mental health teams and also all the services in the community, so that, you know, we can get people before they go to crisis and need a hospital admission. And it's the only way to do it. I mean, we've been talking about, you know, the balance of care for I don't know how many years, like, you know, and we don't seem to be any further forward. I mean, that proportion of the benefit of the budget is pretty bad, like, you know, so we need to do something about that urgently.
Thank you very much, Maureen. And I think in terms of this change programme, I think there's recognition of those interdependencies and the importance of how do you make that shift of financial, not just finances, but staff and resources and the capacity to do that. So I think there's recognition in here. The answer in terms of when and how is we're trying to answer that through this programme, but it will take a whole pile of work to achieve that. You're absolutely right, and we need to make sure that you and the stakeholder participation group are engaged in those discussions, which they are, which is really good to hear. Because that was one of the difficulties before. So I think all I'm doing is agreeing with what you're saying. Thanks.
Maureen, are you content with that? And I'll move on to Sheila. Sheila.
Thank you, Chair. I have two questions, if I may. One is on priority 7, which is the section on engagement with patients, families, partners and communities. And I note that, well, I have a comment to make. First of all, I think this is welcome that this is there. I think it's extremely complex, and I think it probably needs to include emergency services who are very often involved in responding, being the first responders to a crisis situation. But what I want to ask a question really about is about the timeline, because by the 31st of August 2024, there will be a learning shared, and then we move to business as usual. I would like to think that this would be an ongoing process of engagement going forward. And is that what business as usual means, or does it mean?
Oh, do you want me to answer, Sheila? Sorry. Yeah, I think that's what that's saying is that what this does is become part of the DNA of the work that everybody's involved in, rather than the work's done and that's it, finished and closed. So it is about ensuring that that engagement and the capacity for that engagement and the skills around that are embedded across the workforce. Yeah.
Thank you. That's very reassuring. Perhaps the wording could be updated to reflect that, because it just gave me a little bit of alarm. On that same note, I perhaps would suggest that maybe as a lessons learned, they might want to look at the experience panels that were set up by the Scottish Government for the social welfare system, which was extremely helpful of getting individual members of the public, because while there are interest groups and advocates, there are very often situations where people require mental health or sorry, inpatient care. Very often is a crisis situation, and they're not necessarily engaged in any other way or meaningful way, but would be more likely to engage in something that perhaps is more accessible to them. So I would suggest you maybe look at that and take that on board. And then, if I may, Chair, my second question is around priority 10.
Sheila, do you want Jackie to deal with that?
Sorry, it was more just a comment on the experience panels, just a suggestion.
Okay, right, that's fine.
The whole system redesign of learning disabilities. I think this is a very welcome expansion to understand about discharge as well as prevention to some extent. But I would suggest that very often the things that are being advocated here probably could be expanded elsewhere. And I still would wonder, again, would this be a circular process?
Thanks very much for the focus on priority 10, because just recognising that there was news coverage on this very area in terms of the Coming Home report and the execution of that this morning. I suppose this is what's contained within the whole system change programme, and very much focuses on the redesign of the inpatient estate, but we probably as a local partnership and as an IJB need to ensure that we've got the connection to our local transformation of our learning disabilities services, and express it in a way that allows the IJB in Perth and Kinross to see the connection there, and similarly with our community mental health strategy. So there's something in there about this is very much focused on the inpatient services, but we need to see the connection to our community services, which is sitting with Kenny over there. He might want to say something about that.
Yeah, just to back up what you said, Jackie, there's a lot of developmental and transformational work going on in community LD and autism services and community mental health services. And yeah, we are obviously making sure that they're joined up with the Tayside-wide redesign that's ongoing as well. You know, it's a lot of the same people in the various groups as well, so the links are there, and we are confident it will be all joined up into a whole system, so to speak.
Thank you. I mean, I know I've raised this before, but people with learning disabilities, depending on which disability they have, very often have great difficulty making themselves understood, so that by the time, you know, a mental health issue does arise, it's often at a crisis point. So I think the whole prevention piece is hugely important. So I welcome this priority 10 in the way it's structured, and I will watch it with interest as it progresses. Thank you.
Okay, I have one more question. Ian?
Thanks, colleague. The thing I like about this report is that thinking back to 12 months, 18 months ago, how different the situation was in terms of both the service that was being provided, and secondly, the need for leadership to change that. And like any other complicated report, there's always dots and T's and full stops to be put in. But from a general point of view, it's a tremendous move forward, which could be maintained to ensure that Maureen and her colleagues are involved in this at every stage it's possible. I want to ask a question about the timescales, and this isn't trying to cause a problem, but short term, I know it's 20 years, 21 years, and in that period there will always be, by the nature of the skill and knowledge of people in these fields, changes in practice, potentially new drugs, new ways of working in the community. And so there are always going to be, within that, change take place, and hopefully positive change. But can you give us any idea, when you drop this, as just to say that it's short-term options, when you clear it, what does short-term actually in practice mean?
Can I think about that and come back to you? Because actually, because in answering that question, we really need to be focusing on the longer term and what the ambition and the vision is for the future. So and hopefully we can bring that forward in due course. Yeah, thanks.
Sorry, my last point really relates to the issue around capital resources in terms of improving services. Even if we didn't want to do that, we'll have to do it in an event over Carsview and other facilities, not just because of the PFI ending, but also, of course, because the view of the carers and family representatives that neither of these units are capable of changing services in a positive way. And I was wondering, in relation to this, as part of the review that's taking place, is in fact, at some point that Maureen made, the review that's taking place, is it possible to ensure that we look at the assets, the capital assets, and this would be useful because some of the statements later on in the report about working with other organisations and looking for good ideas, these are some of the ideas that I believe can make significant helpful change, and to do so in a reasonable order. And so I want to try and make sure, if we can, that we look at the assets that we have. Also,
thank you very much, Ian. I think you make a really well made point there, because there are assets across the whole of Tayside. It's not all about Carsview and that particular centre. And I myself did a tour of the whole of Murray Royal Hospital just a few weeks ago with Evelyn, just to understand its capacity and what opportunities may flow from that. And the executive leadership group, at each of the next 3 meetings, are actually going to take place on site and do a physical tour of each of the buildings. So in answer to your question is that yes, we're turning our eyes to that just now. Thank you.
And final question, Colin.
Thanks, Chair. It was really, I think, a follow-up to Sir Ian's point about actions that we might take in the short term. Specifically, I wanted to focus in on Priority 1, Phase 1, number 3, which was due by the end of May. And the second part of that is that there should be communication engagement with a wider group of internal and external stakeholders prior to submitting a plan for a rapid short-term contingency for approval by NHS Tayside. Clearly, in the past, many external stakeholders were concerned by some of the proposals that had been floated for contingency within the inpatient mental health provision. And I just wondered whether that communication and engagement had happened and why the contingency plan would be approved by NHS side rather than the IJBs.
Thank you very much. I think the phase one of priority one has changed slightly since the last time it came forward. As you can see, I can confirm that we've had an interim report from the workstream leads around this particular area, and that came in before the end of May for consideration, and that is not advocating any rapid short-term changes at this point in time because of the interdependencies that we've described previously. So there will not be a need to come forward with a report to NHST side. But the reason that was, I think, in point 3 for approval by NHST side would be around making any necessary changes around patient safety, and that's a responsibility of the operational management which rests with NHST side.
Thank you. I'm now going to move to the recommendations in the report, and it's recommended that the IJB approves the Mental Health and Learning Disability Whole System Change Programme, notes the emerging partnership with the V&A in Dundee, and notes the additional investment required to deliver the programme. Do we agree with that? Okay, thank you very much indeed. We will now move on to the next item, which is the Strategic Planning Group, and there'll be a verbal report by the Chief Officer, and after that we'll take a break.
Thank you. I think Zoe's going to present this because I think you've heard enough from me already. Thanks.
Okay, so the Strategic Planning Group meeting was last held on the 25th of April, and we discussed a variety of different topics, including the primary care strategy, the primary care premises strategy. We had an update from Scottish Government in relation to the strategic planning, the strategic commissioning plan guidance. We had a risk appetite presentation, an update on some guidance in relation to planning with people, a high-level update in the carer strategy, and we had a look at the palliative and end-of-life care patient carer advert. I'm not going to go into a full depth of detail about the different papers because we're going to discuss them today, but just by way of an overview, in relation to the primary care strategic delivery plan, Dr. Danny Smith provided an overview of the plan and progress to date. Went through a series of examples of that progress, for example, redesign of the GP role and development of priority areas inclusive of pharmacotherapy, vaccinations, CCATs, first contact physiotherapy, social prescribing, urgent care, our home visiting service, primary care, mental health and wellbeing. The plan had been consulted on widely, but not with the public as yet. Social media assets have been developed along with a communication participation and engagement plan, and public engagements are planned as part of the ongoing process and approach. With regards to the primary care premises strategy, it highlighted issues with premises and how it links to the quality of care provided to patients, including the challenges and opportunities through the current partnership model of general practice. And they covered some areas of discussion such as proposed new GP contracts, a need to consider what's required to deliver new services and where staff members can be accommodated within practices, demographics and where new housing developments are planned and how we develop premises in tandem with that activity, and long-term sustainability of general practice. Key priorities will be discussed in more depth this afternoon, but progress to date that was highlighted was in relation to primary care team have now been invited to the Perth and Kinross Council to comment on planned housing activities. There's been closer working with Angus and Dundee HSCPs to minimise risk to GP sustainability, and several practices have received funding through premises improvement in 22-23, and bids for funding for 23-24 are being sought. a very similar approach to the consultation activity in that it hasn't been done so with the public yet, but there is a plan in place and that those engagement sessions are part of the ongoing process and approach. Points and questions raised by the group were in relation to closure of some surgeries. Blair Athol in particular was mentioned, and the group were advised regards the risks that were associated with that particular practice around lone working and the building no longer being fit for purpose. Rural transport issues were highlighted, and that transport within rural areas was a particular issue and that accessing appointments was becoming more problematic. A question was asked regards new planned housing activity and would it include new care homes. We discussed the fact that the Health and Social Care Partnership are given the opportunity to comment on new developments and new care home proposals, but that wasn't planned at this juncture certainly. The Third Sector Forum representative expressed that they could offer additionality within the strategy. They felt this would allow them to support more easily, as they already do in some areas, rural areas in particular. That third sector organisations can work in partnership with clinical staff to provide holistic support, not just clinical. They help with lifestyle issues and can provide access to additional services. They were commenting that they could situate themselves within branches and that the way that the branches were run could be adapted, and they would be happy to connect in with that work. So the strategic planning group, third sector membership, will be connected in with the primary care leads to ensure a whole system collaborative approach to the use of facilities. We had a very short overview of the refresh of the strategic commissioning plan guidance from a representative from Scottish Government. He let us know that a short life working group had been established and that a draft new guidance was completed. However, due to ministerial changes, the documents are still going through an internal Scottish Government legal check. But once that's been completed, we'll get that for review. Chris came and gives a risk appetite overview and highlighted the need to update the risk appetite statement and then refresh the framework for Perth and Kinross, and that we will be holding a further IGB development session to look at the outcomes of our first session that we held. And the strategic planning group noted the requirement for a risk appetite statement. Karen Sharp, who's the strategic lead for carers, attended and provided a very high-level overview of progress on the draft carer strategy, and the strategic planning group will be asked to review this when it's available. And the people with lived experience of palliative and end-of-life care patient carer advert was presented and discussed. Comment was made about one of the lines in the advert and could it be edited to make sure that it didn't come across as sounding discriminatory or unfair, and that comment was taken on board and assurance given that that would be reworded. The advert has gone out and it's had a high level of interest. Jackie added on the refreshed planning with people guidance and that there's some further recommendations have been added to that. We discussed the fact that we will pull together a report which will be compiled from our self-evaluation of community engagement, and we'll bring it back to the strategic planning group with a series of recommendations and how we might move forward, and that will contribute to our refreshed communication, participation and engagement strategy.
Thank you very much indeed. You can take breath now, Zoe. You ran through that like a racehorse. It was amazing. I'm going to take Sheila McCall and then Colin Stewart.
Thank you very much. So my question really is around the engagement with the local development plan review that's starting off here in Perth and Kinross in relation to property and developments and settlements. I just wondered what plans, if any, this group has to engage with the LDP process.
I'm going to pass this one over, I think, to somebody else who might know. We have, however, had the local housing strategy come to the group and be presented, so I would anticipate that any other plans that would impact the HSCP will come our way, certainly, but I don't have an update on that.
I think in answer to your question, Councillor McCall, is that the LDP and the development of the new plan is likely to engage with the Health and Social Care partnership management team. And if there needs to be further engagement, then we can facilitate that. But we haven't been approached so far. But I can pick that up.
I think this is quite important because this is how communities are zoned and developed. I know out in Bertha Park, for example, there was some planning specifically put in place for certain types of facilities, and very often there's a cumulative effect, you know, where there's maybe lots of small individual settlements, but collectively there's probably a tipping point where you think actually we need to have something in this wider area. And I wouldn't wait to be asked, I would just make sure that you're asked and just asked to be included. And while I appreciate the housing strategy came to you, I think this is one where you almost need to go to them and provide input and be part of the engagement process. Thank you, Chair.
Colin?
I think Chris was wanting to come in and then.
Oh, sorry, I missed you.
Maybe Lisa on the same voice.
Aye, thanks. Yes, it was just in response to Councillor McCall's comments. So within the last month or so, myself and Lisa Milligan from Primary Care have met with colleagues in planning in respect to preparations for LDP3. So we're very much on the front foot.
Very good to hear. Thank you.
Okay, Colin?
Mr. Chair, my comment was just in relation to the discussion that you mentioned about Blair Athol and the concerns over both A, lone working and B, fitness of the premises. And I think, if I recall correctly, when we were discussing the proposed closure of the branch, both of those points were dealt with by representations from the community who would have volunteered in terms of making sure that there was no lone working, and also who provided the information that the estate had done improvements. I can't remember what the name of the estate is, but the estate had done improvements to the property where the branch surgery was located. So I just wouldn't want those continuing ideas to pervade, if you like. Thanks.
Thanks very much indeed. And just a question, I noticed it's section 4 of the minute, the strategic commissioning plans and the overview by Michael Ross. Was that Scottish Government instigation or our instigation?
No, Scottish Government coordinated that activity, so there's representatives from about 5 HSCPs. We are on that group who are reviewing the original documentation that hadn't been reviewed since we were integrated, and it was felt that the guidance was now out of date. There's also seems to be a reasonably large amount of confusion around the word commissioning in it as well, which has actually been removed now. Yeah, so it was initiated by them, coordinated by them.
Thanks very much indeed, Zoe. You know, I quite welcome the idea of other partners coming in to inform various parts of our work, Jackie, and maybe that's something that we will welcome in other areas as well. Thank you very much. Okay, we'll now take a break and then we'll go into a presentation that's going to be done by Hamish on a presentation overall between primary care strategy and premises strategy, but we'll deal with the papers separately. So Hamish, if you want to have a break, we'll have say about 10-15 minutes at the most. I'll call you together when I feel ready. 10. Hamish, do you want to introduce yourself and just say, for some people who may not be familiar out there in the ether who are listening to this?
Thanks, Bob. Yes, I'm Dr. Hamish Dougal. I'm the Clinical Director for the Health Australia Partnership and have been for the last 7 or 8 years. I should start off with my conflicts of interests. Despite my youthful looks, I've now been a GP in Perth and Kinross for 25 years, so just hitting a quarter of a century this summer. And I guess my conflict is that I remain passionate about the delivery of primary care services to our local communities. One genuine conflict is also as I'm a GP partner, so I have an interest in primary care succeeding, but I don't think that is actually a conflict with this. I want to also acknowledge the work of three people, Danny Smith, Lisa Milligan and Beverly Finch, who've done a huge amount of work in both of these strategies, as have many other people, but they've primarily led this work. And Lisa's online to answer any of the awkward questions you might have, while I'll bat the simple ones going forward. I don't have control of the slides, so I'm afraid I'm going to have to go through the laborious bit of saying next slide all the time, so please bear with me. I'm just going to run through both strategy documents because they're both interlinked, and I think after that Bob's going to take the recommendations and questions about both of them. So can I have the next slide, please? So this is the strategic delivery plan. You've got the document, and there's 4 key priorities, which I'm going to go through briefly in a few minutes. That these cover 3 strategic areas. Next slide, please. The context of the document is there are various contexts. The 2018 General Medical Services contract. Now this is massive. If we were sitting here 10 years ago as the previous CHP or the LHCC or before or even at the start of the inception of the integrated joint boards, we probably wouldn't be having this conversation because primary care was very much, there wasn't much involvement at this sort of level, but with the inception of the GMS contract, this has led to the development of services which are financially delegated to the IGB and are operationally managed by the partnership within our area, and that budget runs to almost £5 million a year now. So those services are supporting our GPs within their practices and their patients within the communities, and it's a very significant number of staff now. So we are now seeing that GPs are looking to the partnership to support the services going forward. Can we have the next slide, please? The demographic context you'll all be very aware of. The projected change over the next 20 years in our over 75s is 50%, and that is the bread and butter complex healthcare that GPs are dealing with all the time, and that takes time. So that simple consultations seem to be a thing of the past now, and GPs and the 2018 contract, which I've referenced, talks about the expert medical generalist, and that is really the role that the GPs are taking over and doing more and more, particularly given the demographic change we're seeing going forward. So that change is still to come, that massive increase. So we do need to plan for how we support these services going forward if we value them. Next slide, please. The other context is obviously demographic, and whilst we don't, as seen on this side, have a high level of poverty and deprivation within Perth and Kinross, those areas do exist, and we need to be very mindful of those. Next slide, please. The other area that we know is very significant in Perth and Kinross is the geographical disadvantage. And if you look at the figures, most of Perth and Kinross is ranked in the top 10% of geographically disadvantaged. And we've heard that alluded to in conversations earlier. And next slide, please. And that's borne out when you see the distribution of GP practices across Perth and Kinross. There's quite a lot of information in this slide that you might want to absorb at your leisure going forward about where buildings are, who owns them, etc. But the bit that I would draw your attention to is the 4 arrows there, which really directs you to where the branch surgeries are. And we know there was a 5th arrow with Blair Athol before, and that no longer exists. There are no branch surgeries in Dundee or Angus anymore, and those are the things in the past. So it's not everyday practice, and in Perth and Kinross we still have 4 of those. If we move on to the next slide, please. Over the last 15 years, I think that slide goes back to, well, it's 18 years, 2005, the number of practices in Tayside has fallen from 72 down to 61. That's a significant reduction. And I would just highlight to everybody here that GP practices are not part of the IGB or the Health Social Care Partnership. That's maybe a statement of the obvious, but if somebody decides to hand back a contract, that's their, nobody can persuade them or tell them not to. So we haven't got direct management of those, and therefore the way that we intervene and support has to be very carefully thought through. Next slide, please. Now that reduction in practices, you may not be able to read the small print there, but I wouldn't worry too much about that. That's the regions of Scotland, and you can see the general trend is for the number of practices to reduce, and Tayside is shown there in orange. So we've got reducing number of GP practices, we've got increased local housing, we've got an ageing population, and we've also got changes in expectations of younger GPs who the days of GPs working 9 or 10 sessions a week has gone now, because many of the sessions are, you know, if 2 sessions would be a day, and that might be 12 hours, 13 hours, and they'll still have paperwork to do at the end of it. So many younger folk, and the intensity is also very, very much more significant than it was when I came into practice 25 years ago. Next slide, please. Now that reduction in practices, if you see here on the left, this is the Perth and Kinross practices, Angus in the middle, and Dundee. The practices in black are the practices that have now closed, and you'll see there's been 6 closures over that period of time. The ones in light blue are the ones that have merged, so you're seeing a reduction in the number of practices as practices merge. So in Perth and Kinross, we've seen Cooper Angus, what used to be 2 practices, Aberfeldy and Kinloch used to be 2 practices and is now joined. This chart tells quite a bit. It tells you a little bit about the pressures in the system as well. So the orange practices are the ones who have closed lists. Currently, you'll see there's 2 in Perth and Kinross. A closed list means that all the existing patients within the practice are managed as normal. Nothing changes for them. But if somebody moves into the area and they want to join the practice, they won't be able to. And this is to protect the practices and the services that other patients are receiving to increases in patient list size, which cannot be supported by the practice, usually almost always because of the lack of ability to recruit GPs. So you'll see in Perth and Kinross, we've got 2 of those. These are both temporary, and I'm fairly confident that they will be opening their lists again. And if you see in the Angus and Dundee, you'll see smatterings, quite a lot of red and orange. So I think the pressures are greater there. But I think our challenge as an organisation is to see what can we do to make Perth and Kinross a really good place to come to. How can we support practices so that GPs do want to come and work here? Yeah, and if we go on to the next slide. So we've done, we were quite innovative, and we've presented this to you before about sustainability. This is talked about a lot, but in Perth and Kinross, we took the initiative and we've done quite a detailed survey of practices. We've now done the 3rd iteration of it, and this is a sort of a heat chart of where the greatest pressures are. So you'll see the ones at the top there in the red. There's 5 or 6 practices that we know are struggling to sustain the services they've got. Because of a number of different things. And if we move on to the next slide, it might be useful for you just as a way of background to understand what makes a practice a bit shaky, what makes them less sustainable, because that points to some of the levers that we might be able to use to support them. So smaller practices, and you'll see a lot of the mergers and the closures that have happened over in Tayside and the rest of the country are in smaller practices where small changes in numbers of personnel have the biggest impact. And the days of single-handed practices are in the distant past now, certainly in Scotland. But even with 2 or 3 partners, it's very difficult to sustain that. Many of these practices have been reliant on locums in the past, and locums are just not available anymore. You just can't get them. You used to be able to pick and choose to some extent, so you just can't get them. So small practices, practice where there's large number of patients per GP. So in Perth and Kinross, I think the you know, off the top of my head, that probably ranges from something like 1,000 patients per GP to up to just over 2,000 patients per GP. So you might think that that is almost double the work for one GP in one area and one in another. And the factors leading to that, those numbers, varies from practice to practice. Some of it is an ability to recruit. If you live in a rural area, there's going to be more travelling time, and therefore GPs probably have less patients to look after, although they're working just as hard. So we know that there's a large number of patients, that also puts pressure on practice. Obviously, if you've got a lot of patients over the age of, a lot of GPs over the age of 55, they're less sustainable. Greater dependence on the use of non-partners. They're not as invested in it. Salaried doctors will work more restricted hours and be more protected. And there's absolutely a role for that, because that's what some people need. But where there's a greater dependence on that, makes practices less sustainable. Non-training practices, i.e. those who are not training young GP practice, those who are having difficulty to recruit, those who've got more sites and branch surgeries has been discussed at length within this IGB in the past, but we know that's a factor for unsustainability. So if we choose to support that model going forward, despite the risks, then there is a risk that increases the sustainability issues for the practices, and also the conditions of premises. So if you're a GP wanting to start your career in Perth and Kinross, you'd be looking at the practice that you might go to, and you'd be looking at all these factors in terms of what's my working life going to be like if I go into practice where these parameters are varied. Next slide, please. So Zoe described in her strategic update some of the things that are already going on under the Primary Care Improvement Plan. And I don't propose to go into it because we've talked about that in the past, but that's been a massive amount of work. And if you look on the right-hand side there, the number of full-time staff equivalents, full-time equivalents who are now working in the funded by the Primary Care Improvement Plan exclusively at the end of March this year was 77. So that's going from none back in 2018 to 77, and there's also additional staff supporting that who have changed roles slightly from before the new contract. And with the current funding that we have, we will be looking to increase that up to 88 next year with additional staff over and above that. So we're looking at a complement of about 120 full-time equivalent staff supporting primary care, and that's very significant. However, when we've done an exercise to look at what it would mean to deliver the full aspirations of all the things you see there on the left, we would need significantly more staff, and we would need significantly more funding in order to do that. On the back of the sustainability survey, it's all very well surveying things, but the question that I would always ask myself is, so what at the end of it? What are you going to do about it? The Health Social Partnership, the IGB here, put aside significant funding to support that. The sustainability resilience team a couple of years ago, we're having to change what that will look like because we knew there'd be difficulty in recruiting. So there's now a sustainability group that's specifically looking at how we can better to support the work and to make primary care more sustainable. Next slide, please. So the four key priorities are there. Next slide, please. First one is about endeavouring to ensure our patients' experience of primary care is enhanced. Next slide, please. That's it. And we do that through clear signposting, communication, engagement, ensuring our rural communities are understood. Again, we've talked about that earlier today. Promoting self-management and preventative health, developing our primary care mental health and well-being team. There wasn't such a team. Such a team didn't exist until 4 or 5 years ago. There wasn't investing at the primary care practice level. There was in communities, but not within practice, which is usually or very often the first point of contact. We want to promote best efficiency and safest and quality prescribing because that's a big part of our budget, and we want to communicate the challenges that are being faced in primary care as well, so that people understand, can work with us to bring about that change. There's a lot of kind of strap lines there, but I'm very keen that those are translated into actions, and we'll be looking to bring those forward in the coming weeks and months. Next slide, please. The second one is to ensure that we've got delivered sustainable services. We need to engage with our practices and clusters. We need to look to identify whatever resource we can to maximise the delivery of the primary care improvement plan in full. At the moment, we're stymied by the available resource, and that's something that we need to explore further. We work very much more closely with secondary care colleagues than we used to do. You know, every meeting you go to with them, there's talk about moving more things into community. Lots of things that used to be admitted and patients used to stay in hospital for periods of time. They now get home very quickly, and they need some support in the community, and that support comes through the primary care team, not always through just GPs, but often through that wider team, and that needs to be enhanced. We believe that developing a more comprehensive urgent care visiting will both support primary care colleagues. I think it will improve the whole flow of patients through the system, and will ultimately help our population. And also, we've alluded to before with the surveys we've done, identifying where practices are at risk, and to use whatever levers we've got to support them, so that we don't have more and more conversations about practices having to close because of the pressures they're under. And next slide, please. The third priority is about making sure we've got the right infrastructure. And I'm going to move on to the premises strategy in just a moment, but also IT. And again, this has been mentioned. We've got near me consultation, telephone consultations. We've got prescription ordering online. We've got appointments online ordering. That's all being developed and coming through. Some of it's in practices, some of it isn't yet. But we want to optimise that going forward. Next slide, please. And lastly, we want to look at how we can better contribute to improving population health. There's a significant amount of work goes on in our clusters to try and improve the quality of care, not just about delivering new services. And practices have dedicated practice quality leads, and there's cluster leads within each area which are funded for dedicated time to look at quality. We want to promote resilience in general practice to serve the communities, and we want to foster better links, as we mentioned earlier, with housing, social care, education and addiction services to move things forward. Next slide, please. So there's a number of enablers which are listed there, and for the sake of time, I've mentioned most of them, so we'll just move on to the next slide. So picking up on the, do you want to move to the next slide? So I'm going to move on to the premises strategy. That was under the strategic bit that I mentioned on part 3 there, and I'm going to move through this quite quickly. Next slide, please. When we started this premises strategy, this was a few years ago, when well, it probably was a few years ago actually. It was pre-COVID. We started trying to write this and get a handle on it, and then we kind of stopped moving forward because COVID just overtook absolutely everything and took up all of our time. And when we came back to it, we probably felt that this was slightly back to front. You really want a strategy before you work out what premises and infrastructure you need around it. Hence why the strategy has come first, and then the premises. So next slide. So the first areas there, they've been covered already. It's duplication. You read a slightly different slant in the document, but I don't propose to go through that. Next slide, please. In terms of planned housing, we've talked about that before. Chris Jolly, who's sitting here, has led quite a lot of work on just engaging with planners better and trying to develop our contributions much better considered in the whole planning process. There are very few areas in Scotland who do this well, and Chris has led a bit of work in making sure that we're much more astute about how that happens going forward. So we know in around Tayside, these figures are slightly, in around Perth and Kinross, we know these figures are slightly out of date, but clear message is there's lots of new houses being built. We see it around ourselves, and there's lots more to come. Move on to the next slide, please. You probably can't see this particularly well, but if you look at the left-hand axis there, those go from 0 to 4,000, and the blue bars represent the changes in numbers that the individual practices might expect to get once all those housing are in place. So even the fact that one of those blue bars seems to tickle the 4,000 number, it should be a great cause for concern given the pressures we've got in the system already. So these are going to bring real pressures, and we've got that alongside the ageing population. Move on to the next slide, please. So health and care services, we've mentioned before, there's a move to move more things out into the community. We have our community care and treatment centres now, which are completely new. These didn't happen. These weren't here pre-2018, so we're now running units in a number of different locations. Some of them are brilliant, and I recently visited the Blairgowrie one, the Crieff one, and the Pitlochry ones, and they're excellent facilities. But in Perth City, we're still operating out of Beechgrove House. We have no facilities going forward when Beechgrove closes, so there's a real urgency around that. We've also got pharmacotherapy hubs. We know that to cohort our pharmacists, our pharmacy technicians, is more efficient and can support more practices. And therefore, not only do we have pharmacists and pharmacy teams in individual practices, but the pharmacists themselves finding that if they cohort themselves in a hub, they can deliver greater efficiency. And lastly, in terms of health and care services, again, my dreadful colouring in, I should have got my granddaughter to do that. But the blue line is the river that runs into Perth, and the red splash there is the only area in Tayside which has no GP practice cover from Perth and Kinross practice, and that's the Abernethy area. So when the Newbury practice closed their list 18 months ago, there were no GP practices who have coverage of that area. So, and I don't think that's good practice. My own view is, when I'm asked to comment on practices wishing to change their boundaries now, if there's less than two practices covering an area, then I'm reluctant to support it, because we need that resilience within the mapping. But we also don't have any services there at the moment. Newbury have reopened their list, but that's left a number of patients who had to register with Perth practices who don't geographically cover that area are still having to look after those patients, so have to go out on home visits to that area, and that takes them away from their normal population. Next slide, please. Current considerations, the current distribution of GP premises, I think, is largely appropriate. I think when I showed you the map earlier, there's a fairly good distribution across it. We have got a number of branch surgeries, which I've mentioned before. Lease assignations, the map that I showed you and I said that you might want to pour on a little bit will tell you whether the NHS own buildings. Now they only own one building in Perth and Kinross, that's the Aelith practice. Drumheart Health Centre is owned by the council, and there's I think it's a 100-year lease to the NHS. So, but most of the other practices are either leased to a third-party developer, or leased from a third-party developer, or they're owned by the GPs themselves. Leases are a big issue, and they have been since the 2018 contract, because if your practice fails, you're still liable for the rest of the lease, and that is significant sums of money when you have no income at all coming in to cover it. And that, in reality, does lead practices who are struggling to recruit. It leaves the GPs having sleepless nights and being very, very stretched, because they are personally liable for that. So the GP contract has put the onus on NHS boards to take on leases, so the leases should be assigned in due course to that, so that they would take on the premises liabilities going forward. And that process is, we're seeing that occurring in some places in Tayside, but it's probably one of the biggest things that GPs would say would help them recruit, because new GPs coming in don't want to take on those liabilities. And lastly, obviously, stakeholder engagement for any changes going forward. So if we move on to the next slide, we're not long to go now. And then the next slide, please. Next one again. So these are the 9 key priority areas. Next slide. I'll just briefly run through these. So this is in terms of premises and structure of delivery for primary care services. We know that Perth City has got 8 practices within a 450 square metre radius, and with the increasing expansion on the west of Perth and also to the south. Perhaps that distribution is no longer optimal. We also know that already, if you look at the Scottish Health Planning Notes, it gives guidance on how much square footage or square meterage you should have for each GP provision within an area. And we're already very significantly down on what we should have in terms of space within the buildings in Perth City. We've got about 1,200 square metres short in Perth City alone, and with the new builds that are going on, that will almost double that. So we don't have enough footage to provide what the Scottish Government planning notes say that we should have. And you'll also see that, so I think looking at a costed options appraisal on the possible future modelling of GP practices around Perth, including Bridgeverne, Abernethy, where I've mentioned to you already, we don't have any cover, and the west of Perth is something that we need to take forward. That's going to be a very complex thing. We'll need to explore quite complex contractual routes, because if you start up a GP practice in Bertha Park tomorrow, you will have no patients, no income, and somebody will need to provide your premises. The NHST side can't unilaterally decide to move a chunk of patients from one place to another in that circumstance. And part of that will be about whether there can be some optimisation of redefining the historical boundaries that practices currently cover. So we would hope to come back with an options appraisal at some point in the next period of time. Next slide, please. I've mentioned this already, so I'll not labour it. We need premises for the Perth City community care and treatment services, so that Beechgrove House can be taken back from the council could take it back for the use for which it has intended. So we need to again work with NHST side to find the suitable premises. Next slide, please. The CARS practice in Errol have been working having visited them in their previous practice. This is a vast improvement, but it is a temporary structure. The lease runs out in 2025. It may have a further extension beyond that, but we need to take a business case forward, and we need to be really clear about where the responsibilities lie in doing all of this work, and how we can push that over the line to get some commitment to developing a new premises. And that's all been highlighted all the more since our Invergowrie practice closed. Next slide, please. Lease assignations I've mentioned to you already, and just to give you an idea of the urgency of it, there's 6 practices and are going to have their lease expires in 2026, and thereafter there'll be a few others. So these practices are desperately keen as they come to the end of their leases that the NHST side takes them forward. The earlier I think that those leases are taken over, the more attractive Perth and Kinross will be to come and work in, because new young partners won't be facing lease liabilities and potentially large dilapidation charges as the developers ask for changes to be made in the buildings. Next slide, please. I think we need to work sensitively and sensibly in collaboration with practices regarding the future provision of branch surgeries. We've already said that small practices and branch surgeries lead to lack of sustainability. So what is the best model for those going forward? How can we work with practices to support that? Next slide, please. There's opportunities for better value perhaps, and we need to work with NHST side to see within each area whether there's alternative ways in terms of premises that practices can be delivered. But I think the important thing from our perspective is we think that the areas that have got GP practices at the moment, bar save the comments I've made about Perth City distribution, are appropriate. So Pitlochry needs a GP practice, Crieff needs a GP practice, all these things. So we think the distribution is appropriate. Next slide, please. Again, I've alluded to this before, the primary PCIP is a primary care improvement plan. We need to look at the opportunities for delivering the full plan and going beyond that. Just how can we have a really robust primary care services in Perth and Kinross, so that practices are on the front foot, able to deliver the proactive preventative care that we often talk about, rather than the reactive, delivery that often they may feel that they're forced into because of current pressures. Next slide, please. We need to assess the potential for improving premises. We've got those 120 odd staff. Many of them are in GP practices that are now overcrowded. Pharmacists, first contact physios, social prescribers, mental health nurses are all dashing in and out of rooms that GPs have just vacated or practice nurses have vacated. So how can we make it a good place and an optimal place to go? Next slide, please. Lastly, we need to look at ways of reviewing the operating costs of premises. Where is there opportunity for efficiency, for more eco-friendly heating systems, lighting systems, renewables? That's not a high priority for a lot of GPs when they're facing pressures at the moment. But if we can support that, that's where we want to go. Next slide, please. Next slide. And that's me. I'm very happy to answer questions. I would like to bring Lisa Milligan in just briefly, because one question you will have, or you may have, is what consultation has taken place in this. And I think there has been quite wide consultation, but not public consultation, which we've alluded to, that each of these elements of this, where we're developing them and going forward, will require that. But in terms of stakeholders, I wonder if, Lisa, you might want to just describe what has been done in terms of getting other people's input. Thank you.
Thank you. Engagement began with an evening event for the GPs, and practice managers and practice staff were invited in early December 2022. The event was really well attended actually, and had representation from all the invited practices and from HSCP staff members. This gave people the opportunity to discuss any key questions that they had, and the strategies were explored. And I think the feedback that we had was this was a valid introduction to these. And then we began a fuller period of engagement with internal stakeholders. The two documents, they were then circulated with an online survey, and that was distributed widely from the 22nd of December onwards and ran through to the 20th of January. In addition to that, we had plenty of team meetings going on and face-to-face meetings with clusters and GP groups. And the survey started really to gather the views of the people, whether they agreed the priorities we had identified were indeed the priorities that they felt were important to them, to seek any further suggestions, and also just to give people a chance to comment on either of the papers, both of the papers, or directly with ourselves. We got a lot of detailed responses back to the survey, and people were encouraged to circulate it widely. So we, in terms of direct receipt, the document and the survey reached just over 200 people. In total, we had about 37 responses received back. The majority of them were from GP practice and practice managers, but we did get some from other groups and other sectors, which was really helpful. The suggestions were then reviewed and recognised as supportive and valuable for the themes and for the suggestions and for the personal element that then brought into, and we incorporated these into the reports. We have said that we'll do continual involvement, engagement with stakeholders, as it's critical to the success of the delivery of these two strategies. And this is emphasised in both the documents, and there'll be an ongoing process with more focused engagement that'll be taken as required. But we have found that it was extremely helpful to get that feedback from everybody, and hopefully these final documents are reflective of that engagement.
Thank you very much. There's quite a lot of information taken there, Hamish. Thank you so much. We're still going to have a detailed look at each of the separate papers, but I'd like to get some general feedback response from the presentation. I see that Sally has a hand up first of all, but I don't know anyone else. But Sally, we'll start off with you.
This is more a general thing about the work that's gone into this. So conflict of interest. I've been a GP for nearly a quarter of a century, but not quite yet. And what I would like to do is really thank the team for the amount of work that they put into this. Last time we were presented these at the IJB, we asked them to go back and speak to the stakeholders, and I was absolutely thrilled when I read this report the other day. It captured the conversations that I'm hearing day to day with colleagues. I was around on some of the meetings that were undertaken, and I think that the concerns and the thoughts and ideas of our frontline staff have really been taken into consideration. I think that's a real positive. I think it gives a realistic but aspirational strategy for us to think about. But one of the biggest things for me is being able, as Hamish says, the GPs aren't under the Health and Social Care Partnership, the IJB, but by having these conversations, I'm feeling really optimistic that by building that relationship and us listening to each other, we can really support the sustainability of primary care in P&K.
Okay, thank you very much, Sally. Martin, do you want to come in next?
Can I have some clarification on the buildings, and there quite a few times you talk about premises. My understanding was previously that the buildings or premises were leased, and that the responsibility that the NHS would keep them wind and watertight, and then it was up to GPs and practices to enhance their premises. Then MOU 2 comes along, and it's like we're trying to say, right, okay, these premises have now outlived their usefulness and their payment, but we need now somebody else to take on the role of upgrading the premises. Am I right in that assumption?
I wonder if you could put slide 7 back up on the screen, if that's possible. Might be helpful if I just explain it. I don't think anything really changed with MOU 2, other than the fact that there was an emphasis put on health boards to take over the responsibility for leasing or ownership of the buildings where practices wanted that. So if a practice doesn't want to do that, then the standard status quo can be maintained. The majority of people who lease a building have got no financial interest in it. They simply want a good working environment, and therefore it's more of a risk than anything else. If you look at the slide up there, the red dots are NHS owned buildings. I did say to you that there was only one, but I've counted Drumhar as one, even though it's not. The blue dots are the ones that are leased. So all of the blue dots there, and you'll see there are many, are ones that the GP practices entered into a lease contract with 20 odd years ago, most of them between 15 and 22 years probably for most of the practices. That was done with the full support of NHS Tayside, who helped with the contracts at the time, and there was an understanding that given, and the irony in some of this is that in some practices there's a lot of NHS employed staff, but yet the individual GPs are the ones who carry the personal financial risk. But at the outset of the leases, it was understood that that there would be an ongoing payment to the practices for the amount of space used by NHS staff. So what happens is that the building is leased by the GPs with their personal liability, and the rent is reimbursed to the GP practice, plus somewhere in the region of 4 to 6% to cover buildings, insurance and maintenance costs. So NHS Tayside has no, and never has had in those buildings, any maintenance responsibilities. The yellow dots and yellow triangles there, those are the GP owned ones. So there's a number there. There's 3 in Perth City. There's a couple of branch surgeries, and there's a couple in Blairgowrie, one in Blairgowrie and one Auchterarder. They're owned by the GPs, always have been. The rent they receive goes to pay their mortgage, and if they don't have a mortgage, then that is a profit. And that was one of the things that was attractive in terms of ownership in the past, because once you paid off your mortgage, you're getting that income. It's a commercial income. You're your own landlord and your own tenant. So it was probably seen as quite a good thing. Whereas now that's flipped and it's seen as a risk. So I hope that answers the question. In terms of the buildings, yes, you've NHS-owned ones. So Alyth and Drumhar are ones that you would expect NHS Tayside to maintain. That they would have responsibilities for those.
Okay, thanks. I'm going to take Sheila McCall, Beth Hamilton and David Illingworth.
Thank you. Thank you for that rather comprehensive slide presentation. I think there's such a lot of information there. I'm not quite sure if I can take it all in one sitting, and it's maybe worthwhile, Chair, to think about maybe doing something specifically similar to a development day, just so that members and stakeholders can have more of a chance to assimilate all the information and perhaps, you know, get better informed about what's going on. As an elected member here, I know that my casework has often has a lot of issues around access to GPs and getting appointments, etc., and it's quite difficult sometimes to be able to address those issues. So I think that would be quite helpful. Just a comment on the CCATs. I do remember, I'm old enough to remember many years ago when in fact there was clinics in local communities where you went to get your baby weighed and your diphtheria sugar lump, and you know, they were very important facilities. So although I know you like the hub and spoke, I'm probably on the other side of the fence a little bit to think that perhaps we need to consider, particularly in areas of high deprivation, how we can perhaps bring services to where people live, because they very often won't go somewhere else. And so I would maybe ask you to consider that. And as part of that consideration, you know, you talked about hubs being more efficient. Well, I think as a single entity in their own right, that might be correct, but the impact on public health might be more efficient overall in terms of whole life costs. I don't know if that's modelled or not, but it's just, again, an observation. But I do have a question about public health. I'm just wondering what part of this process is involving either Public Health Scotland or indeed the Public Health Committee at NHS Tayside, because one of the focuses there is around prevention and services. So it's just, I'm wondering how aligned this piece of work is with the work of those organisations. Thank you. That's a lot of information, but only one question I think at the end.
Well, there's two. I would say in relation to the pharmacotherapy hubs. So these are not hubs; these are administrative hubs that we're talking about. So not ones where patients are going in and out of. So just for clarification, in terms of public health haven't been involved in this process of this strategic document, but it is absolutely something that I feel very passionately about, as you've described, and I've been trying to engage directly with public health colleagues in terms of how we can be more proactive in what we do, and I hope that will come through in the work that we bring forward going forward. I very much believe that if you can take away, if you can assess what all the barriers are to individuals getting that help, that screening, that support, that treatment, if you can understand what the barriers are and then develop a service which removes those barriers then and gives them opportunity. We know that patients won't take up all of the opportunities for screening, but we know very much that there is a clear socioeconomic and geographical divide in people taking up that opportunity, and I think I'm very keen to work with public health about how we can do a bit more to try and overcome that by the way we design our services.
Sheila, we'll pick up on that question you raised about having more time to visit these issues. This is almost as important, that part of it, than actual making decisions about various strategies or individual circumstances. Thank you. I'm now going to move on to Beth Hamilton and David's, and then Sandra Auld and Jackie Jensen, and then I'm going to move to the detailed papers.
Thanks very much, Bob. A hugely comprehensive piece of work, Hamish. Well done. I think this does reflect your personal passion and the work that you do around this area. So thank you for doing that. We touched on it earlier in the meeting about primary care strategy across Tayside and the role of the lead partnership linking in with the model that we're looking at mental health. And I suppose that's my concern of how this will link in and how can we influence the Tayside strategy that's going on. I think I asked you in the past if you felt as involved with the NHS Tayside work and the overall strategy for primary care. And at that point you felt you were. So I suppose my question is, do you still feel as involved and as able to influence what's going on across the area rather than just the Perth and Kinross? Thanks.
I think that's a really good question. I think it is within our gift to define our own strategy. I see the lead agency as being the coordinator of the strategies of the 3 IGBs, and I'm currently working with colleagues in Angus and in primary care services to better map out what all of those responsibilities and definitions are, because I think they have led to vagary about who should be doing what in the past, and I absolutely feel that needs to be clarified. And I don't know, maybe Jackie would want to add something to that.
Only just to say that given the previous discussion that we had around Invergowrie medical practice, that's an area that we would want to include in the lessons learned exercise, so that we move out of that situation with greater clarity and greater understanding about the lead partner role, particularly in relation to primary care services, because of the complexity around that. But what that means for decision making and the responsibilities of each of the IJBs, NHS side board and the leadership team within NHS side.
Thank you. It's just as what was welcome in this one was it did look at the whole area of primary care and not just GPs, but it's also, we need to acknowledge that not all primary care is led by Angus, and like the dental services, we are the lead up service there. So thank you. It's a wonderful piece of work, Hamish, and congratulations once more.
Okay, thank you. We will now take David Illingworth and then Sandra Auld and Jackie Jensen.
Yeah, can I just comment and just say I'm amazed that 4-year-olds were allowed to become GPs 25 years ago. Outrageous. And can I ask 3 questions? So, Hamish, number 1 is what is the process for a GP practice to close its list? Can it do it unilaterally, or does it have to consult?
In terms of a temporary closure of a list, which is what they can't do unilaterally, they have to ask for permission, and usually what happens is that the Associate Medical Director for Primary Care Services for NHS Dayside will meet the practice along with the manager from there, and usually with myself and Lisa, and we'll discuss what we can do to support the practice to stop the list closure, what their expectations, what their exit strategy is from the list closure, and we would hope where possible we can avoid that. But so, for example, the 2 list closures we've got, we know that there are doctors coming into post in a few months' time. They just need a little bit of support meantime, but they can't just do it unilaterally. They need to apply.
Number 2 question is, I'll go into number 3. Number 3 question was about Abernethy, and is it worthwhile considering a marketing plan in conjunction with the Newborough and Abernethy surgery to move the Abernethy patients onto the Newborough and Abernethy GP's practice?
You could have got away with calling that number 2 question, actually, I think, David, rather than having to call it number 3. What you're saying, if I get you correctly, are you meaning the patients who during the closure were allocated to a Perth City practice? Yes, and I think there's probably a sense that there will be a drift back to what is a more local, because they have got a branch surgery in Abernethy Village itself, and we're continuing to deliver that, as far as I'm aware, during the closure. So I think word will get out that it's open again, but we need to be seen to be not applying undue pressure for patients to move practices. But I get where you're coming from, and it's not unreasonable. Yeah.
And the third question is, how do we encourage GP practices to become training practices?
Yeah, it's a good question. Sal wants to answer it, so I'm getting tired of listening to my own voice.
So I knew this question would come up. So I am very fortunate in the fact that in my practice, we've got TPD. I don't even know what it stands for, but she's one of the program developers for training within the local area. And I actually asked her this question about the possibility of how we encourage training practices. And I think what she said was quite interesting, that training in itself is a complex, difficult, time-consuming, resource-filled activity. It is brilliant, and I love having trainees in my practice. But she said you have to be so wary, because we have to ensure that our trainees and our GPs that are coming through are getting the best possible training they can. The other issue that she raised, which I felt was really interesting, was the fact that the training is becoming more complex, and the fact that we are seeing a different cohort of GP trainees coming through. So as part of ensuring that we are still getting trainees to any practice within Perth and Kinross, we have to ensure that the complexity of the training, the quality of the training is maintained. And if this is a struggling practice, if this is a practice that maybe doesn't have the resources or doesn't have the enthusiasm to do it, then we are potentially going to put detrimental in our people who will apply to come into Perth and Kinross generally. So I hope that answered your question, but I'm feeling quite pleased that I went to her and asked her that before this meeting.
Thank you very much indeed. I think you did a good detailed bite there, David. Now going to take. Okay, if you may.
Yeah, it's just, I think it's a good question, and I think you've answered it very well, Sal, so not add to it. But what I do want to add is just a comment. I think with Sandra raised it at the last meeting we had about career start posts, because they are fully qualified GPs, and what our longer GPs want to do is perhaps a little bit of specialty work. So we've had this programme in NHS Tayside for the last 5 or 6 years, which is was initially funded from Scottish Government and is then picked up through the Primary Care Improvement Fund, which I'll come back to a second. So when you finish your training, come out of your GP practice, you can go and take on a partnership, you can locum, you can become a salaried GP, whatever, but many want to just a salaried post, and the Career Start post offers them that. It's a 2-year post where they do a day a week of a specialist role, and they get some administration time, which you don't get in general practice, and you're attached to a GP practice. And it's a really good break into general practice, a good lead in, and it's been a very popular scheme. All of the funding for that has come through the Primary Care Improvement Plan, and the local medical committee, the LMC, have indicated that they won't be supportive of that going forward, coming out of the Primary Care Improvement Fund. So it's a national issue that the other areas have picked up on, but there is no funding stream for that. So it may be that might be something that as an IGB that you might want to look at, because it's not a long-term funding commitment, it's a short-term one. I think that might give us an opportunity to box clever on the finance side of it. Look at our CFO.
I'm running out of time on these papers, by the way, for more general questions. So I'm going to bring in Sandra Auld and Jackie Jensen and Colin and Maureen. I'll give you the final question, definitely. Okay, Sandra.
Thank you very much, and I'll be very brief. Hamish, thank you so much for a really informative presentation. Back at the beginning of it, there was mention of the consultation events, and it was really helpful to get a little bit more information on those from your colleague. I don't know if there was the opportunity for IGB members to attend any of those events, but I know that I would certainly have welcomed the opportunity to do that, and would really feel that would have benefited and kind of increased my understanding of some of the issues, and it would have been really helpful to be able to hear some of the discussion. So maybe for future events or for future future consultations, it might be helpful to be able to include the IGB.
I'll just take that as a comment. I think we did present the draft paper to the IGB some months ago for comment, so there was the opportunity then, but I absolutely hear what you're saying, Sandra.
Okay, thanks very much. Jackie Jensen.
Okay. I learned such a lot from these two reports, these documents. They're really, really good, detailed pieces of work. There's a couple of questions I wanted to ask. On page 4 of the premises strategy, there's a statement that talks about Tayside Health lagging behind other regions in Scotland in terms of lease acquisitions. I can read it if you wanted me to talk, but I wondered if you had the data behind that. And is there something we as a board, or the members of the board who are on the Tayside Health Board, need to take back and discuss with our health partners around where we sit in terms of lease assignations, and is there more for NHS Tayside to do? So the question is, what's the data behind that? How do we know Tayside are lagging behind, and is there a task for us as board members on that board that we can do to help?
I might have given you a different answer 3 months ago than I'm going to give you now. I think I don't have data on it. The LMC had some data. I know from speaking to third-party developers who are the landlords that that's their has been their perception or their experience of it. But I would say that we've noticed a very significant change in the last few weeks in the engagement. And I think what we really need is what is the process, because nobody understood the process, and I'm not sure there was a clear one. A number of the lease assignations that have taken place have been in crisis situations where the lease had to be taken over. But I think we're now seeing very positive engagement from senior people in NHS Tayside, along with the property, to take it forward. So I'm more reassured than I was when this document was submitted.
Thank you. Perhaps maybe think about the wording of that statement then, if we don't have data behind it, but just a piece of advice. The second thing I wanted to ask you about was the IT strategy, and particularly near me. And as my understanding was that it has been rolled out to all GP practices. Am I wrong? And if it is, what's take up like? Are GPs happy about using it? Because when we talk about the patient experience, I've had a few people say to me, my doctor doesn't see me now. So he can't, or she can't look at me and tell things from Luna. I don't know if that's possible anyway, but there is a perception amongst people that they'd like their doctor to be able to see them, and would near me help? So
we can get the data for you. We've got very specific data on it, and I would say that the uptake is it's not well utilised in primary care and in Tayside generally. There are 1 or 2 hotspots where practices are probably more individual GPs are very keen on it. If you ask 20 GPs, you'll probably get 20 different perspectives on it. I think it does have a role, and I think part of what we've presented in the strategy is how we support practices in providing that opportunity where patients want it. Many patients don't want that opportunity, and when you say they want to see their GP, what they mean is they want to see them, like they want to be in front of them. I came across some paperwork from not long after I started my practice 23 years ago, and we were having a meeting about how to improve access for patients, and I think we've had that same meeting every single year for 23 years. It's not that GPs are not interested in it, it's they're just trying to juggle so much to what can be done. And I know if I do a telephone surgery, for example, I can deal with an awful lot more individuals through that. Often I'll bring the ones down that I feel need to be seen or would benefit from being seen, but other things I can deal with more quickly, and therefore I can deal with more patients. So it's a really difficult balance to get. I do hear, like you're doing, that some practices are more difficult to get appointments with or to be seen with. My experience of many practices is that they're really trying to grapple with how to give the right access, and it's about giving the right patient the right access at the right time. And it probably is, there's not enough slack in the system to make it purely a a wish-led system, and therefore we kind of focus probably on more assessing what the need is and responding to that. I would love us to move to where there's much more capacity in the system, that we're not having these conversations anymore. But
okay, and thank you very much. And that takes us on to Colin Stewart and finally Maureen.
Thanks, Chair. What I was wondering about, first of all, was there are certain actions specified in the, for example, the primary care premises strategy. I was just wondering how those are assigned and tracked. I was wondering so that we can monitor progress towards that. I was wondering whether I believe Ms. Milligan said that there hadn't been public engagement. I think we've sort of touched on that in the questions. I was wondering whether there would be a deliberate plan of public engagement, or whether it would just be where sort of communities asked for it, because I think there is a reference to engaging with communities. Community councils would be a great place to start, and certainly, as well as was mentioned earlier in relation to a separate point, the big place conversation leading to the development of LDP3 would be a great place to input in terms of where do we want to see future healthcare premises provided. There's quite an emphasis in the premises strategy on the direction to NHS Tayside and the funding coming through NHS routes, but what I'm not actually seeing is any sort of planned capital or construction costs for future, and I just wondered, you know, if we're only looking at building things, I think it's in a sort of 5 to 10 year time frame, there's an awful lot of planning which needs to happen right now, and so there needs to be a more defined set of actions about where the next premise is going to be built is actually, you know, where it's going to be, who's going to get the planning permission, who's actually going to do the construction and manage that. And I was wondering as well, the council here has a huge property portfolio, a lot of which have over time been declared surplus to requirements, and is one part of the, or should one part of the premises strategy be to rely to think about conversion of existing buildings so that we move towards that single public estate that would be the best use. You know, it's taxpayers' money, whether it's the council or the NHS supporting it. So let's try and break that barrier down. Sorry, quite a lot there, Hamish.
I'm maybe going to defer the last question first to Evelyn, because Evelyn's done a lot of work in the premises, trying to move that forward in terms of the CCAT's delivery, and then I'll come back with other parts, Colin, if that's okay. If Evelyn's still there.
Hello, can you hear me? Yeah, Colin, in terms of the one public estate, we've been quite heavily engaged in the whole process around that, and have obviously we've fed in our accommodation requirements, etc., around CCATs into that one public estate discussion. We still, unfortunately, have not come up with a solution for our CCAT service, but there are a few areas that we still need to consider. So yes, we have ongoing work, and NHS Tayside Estates Department are involved in that one public estate discussion as well. So yeah, it is ongoing. We haven't got a solution yet, but we've got a few other areas to consider and a few other moves that might make the difference for us.
In terms of the, I think you're absolutely right, Colin, that there needs to be detailed information coming through options appraisals, and I mentioned the key priorities, and I think some of those would lend themselves, each of them, to an options appraisal that are quite complex. I don't think we can move on to construction costs and capital allocations until those health needs assessments are done and the options appraisals have taken place, so that we can present those as a considered project. But I think this is, you know, if these papers are approved today, I think that is the springboard to the next bit, which is absolutely what you're describing, and I absolutely get that. Yeah, Evelyn, see you there. Do you want to talk about the public engagement plan, or Lisa?
I think Lisa might be best to talk about that in terms of what we've done so far. That would be helpful.
Well, it's more about the next stage. I mean, I think had we gone out in public consultation generally, I'm not sure that on lease issues that would have been that. There's a number of elements to that I'm not sure would have been that helpful. I think what we want to do now is to go on to the options appraisals, which I think, and we need the needs assessment and the community opinion as part of that. And we're at least, I don't know if you want to mention what's going on in Bridge of Erne just at the moment as part of that whole process.
We've been doing some ongoing work with the Community Council at Bridge of Erne and looking at a needs assessment for that area. That's been running for the past month and concludes in about 4 days' time. To date, we've had about 400 and odd responses, and it has been very interesting. Actually, the level of uptake, the support that we've had from the community engagement workers has been phenomenal, and it's meant that we've gone to every single focus group and community event, the gala. So we've tried to engage very, very widely with them, and also went along to the Stronger Communities event, which was very well received. But in general, the positive responses have been that the health needs are being met within the area, but there'll be a full detailed report that will come out of that consultation process, and we will then obviously publicise that. And we're working with the list department, and they'll help support with the write up of that, so it's done independently as well.
And I think, Lisa's good to say that we're also then moving on to Cardiff Gowrie with the same process. Yeah.
That's fine. Thank you. One final question, and then we'll move to the recommendations of the paper, unless there are other questions relating to those specifically. Maureen, final shout.
Yeah, I noticed that you had up as one of the concerns for the future is the amount of GPs who are 55 plus. Now, is that listed here because they're then eligible to retire? Because if that's the case, can they then move on to being agency staff and come back for a more exaggerated pay? Because that seems to be a drain on NHS. Also, you mentioned about the practices that are run as businesses rather than NHS run, and the amount of rent that they pay for the premises is reimbursed by the NHS. Did I hear right? Is that not? I mean, if they're running it as a business, businesses pay the rent of the premises themselves. I don't see why the NHS should be reimbursing them. But anyway, can you?
I'll probably get drawn into the least one. Yeah, I think, you know, given that 95% of the work that GPs do, it's an unusual contract situation, I personally think. And I think the only reason that we haven't moved across to a salaried model where GPs are just employed is simply the NHS couldn't afford it. They couldn't afford the number of hours that GPs do. To be honest, you might expect me to say that because I'm a GP, but it's a well-balanced system, and that the remuneration for the rent is taken as part of that. Your first comment, you don't often go to meetings where people are promoting more exaggerated pay for GPs, but I'm delighted that you've mentioned that. And I think one of the things that we're looking at as well is encouraging and supporting GPs at the start of the career, exactly as you've described, and the Royal College of GPs in Scotland just produced a document just 2-3 months ago which talked about how can we improve things, and one of the things was talking about, you know, when people do retire towards the end of their career, how can we make it attractive for them to come back in, so they're perhaps not coming back to the same intensity. It's usually not money that will drive them back in. It's probably a better, you know, quality of work with time for administration and not a big long 12-14 hour day. So if we can, and you're right to highlight that, because we haven't really brought that up as part of the strategy going forward, but it's been raised by the Royal College of GPs. Sal wants to come in.
Sorry, can I just come in here? So this is a very interesting issue, and we have a GP sustainability group, and actually this is one of the topics that we've been discussing about how we look at GPs who are retiring and what would support them stay in practice. And so we've started those conversations with people who are coming up to retirement or about to retire, and I completely agree with Hamish. It's not about money, it's about the extensity that they've worked so hard for a prolonged period of time, but also there's a little bit about the admin side of things. We've have to do annual appraisals, which includes you know, up to a regular amount of improvement. So there's a whole complexity around it, but we are having those discussions with GPs who are retiring or about to retire to see if we can keep them in clinical practice.
Okay, thank you. Michelle Frampton.
Thank you. My comment is on the key priorities. Is it okay to go ahead with that comment just now?
Yes, please. Thank you. I think
Right.
it's going to be a different way how we're going to handle each paper, but I'm going to move to the recommendations very quickly. Okay, thank you.
Okay, my comment was based on the priority 5. I welcome the interest by HSCP wanting to explore the development of other health professionals to help supplement the GPs in meth and branch surgery. However, I am concerned that it says it may mean a reduction in the GP sessions of availability at the practice. Currently, I believe meth and practice operates Monday to Friday for just half a day each morning, on the 5 days a week. However, given that I still receive many complaints of where individuals are complaining that they are still unable to see a GP, I think to reduce the available GP hours would have a more negative impact on the meth and surrounding areas patients who are registered at the practice. This looks to me to be yet another disadvantage to the rural areas primary care services, and I just wanted to make comment on that.
I think we hear that comment and we'll make sure that's minuted. Okay, I'm going to move to the papers themselves. There's been a lot of discussion on the areas. I mean, I think one of my own reflections, Hamish, would be, is the concept of primary health care sustainable in the long term when we think about a multidisciplinary world, multi-thinking now around what public health looks like, when we think of its connections to the socioeconomic circumstances of people and all of those impacts. So maybe that might be something that may come up in future rather than just specifically looking at health and what is good health. But I'm not going to follow that any further today. I'm going to go to the recommendations. I think we've had a good airing, and unless there's specific questions unanswered, I'd like to go back to 6.4, which is the primary care strategic delivery plan itself. Are there any further questions on this before I move to recommendations? Okay. Did I get Colin? Colin and Sheila then?
Sorry, I was letting Councillor McCall go first. I think the comment on this is similar to the sort of question I was asking specifically about the premises strategy, but also earlier papers. Is that it would be good to see an action list with dedicated resource against it so that we can monitor progress. And hopefully that could come forward when we get any updates on this. Thanks.
Thank you. Please take this in the right way, but this paper to me is about GP services, not about primary care services in their entirety. And I understand why that is, but I do think that there is a whole aspect of other services that make up primary care, and that somehow we're going to have to think about how do we address their strategic needs and priorities as well. So these papers as they stand, I think, are more about GP services primarily. Part of the fun. Thank you.
Thank you for that, Sheila. And the more I look at this, I just think this is an ongoing conversation for us about what we need and want as an IJB. And certainly in terms of the issue about bringing things together, I think when we do strategic updates on both of these papers around the strategic delivery plan and the premises strategy, I think we should have the updates side by side so we can consider these broader questions as well. Okay, I'm going to move to a recommendation on the first paper, which is the primary care strategic delivery plan. And there are a number of recommendations within it. The primary one is to approve the updated primary care strategic delivery plan as set out in Appendix 1 to this report, which is quite a lengthy document. 2, to note that consultation and engagement with key stakeholders, inclusive of Chief Officer of Angus Integration Joint Board as the lead partner for strategic coordination of primary care services, has taken place prior to submission of the updated SDP, and instruct the Chief Officer to bring back progress reports to the IJB on an annual basis. Issues directions are set out in Section 6 and Appendix 3 of this report. Do we accept these recommendations? Okay, as I say, this is the beginning of a conversation on this. We've much more to go, and I think the development session will help us greatly in this. And then I'm going to move to primary care premises strategy. Jackie, have you got that in front of you, the recommendations? There's quite a lot of scrolling down. Can someone read them out for me? Thank you. If you may, Sheila. Can you read them out, please? Thank you. Oh, right.
Okay, the recommendations. It is recommended that the IJB approve the primary care premises strategy as set out in Appendix 1 of this report. Note that consultation and engagement with key stakeholders, inclusive of the Chief Officer of Angus Integration Joint Board and the lead partner for strategic coordination of primary care services, has taken place prior to the submission of the updated SDP. Instruct the Chief Officer to bring back progress reports to the IJB on an annual basis. And finally, issue directions as set out in Section 6 and Appendix 3 of this report.
Thanks very much, Sheila. Do we accept those recommendations? Thank you. Chief Officer, do we expect Gail to join us for some of these discussions? Do we have an expectation?
I don't have an answer to that as yet without a discussion with Gail, but I'm thinking that it would be helpful at the next update to the IJB to ensure that Gail Smith or whoever's performing the lead partner role for primary care services is in attendance. That would be helpful.
And presumably we have an opportunity if she might be at the development session. So, okay. That's right, I'm on now. Revised carer strategy, Kenny.
Thank you, Chair, and I'm joined on the left-hand side by Karen Sharp, the strategic lead for the carer strategy. This report presents the revised joint carer strategy 2023 to 2026 for young and adult carers. Good progress has been made in achieving the 7 outcomes in the original strategy. For example, nearly 3,000 carers have been supported. Information regarding support for carers has been made available in a range of formats. The number of emergency care plans in place has doubled. The number of people admitted to a care home as a result of a carer breakdown has reduced significantly. Support for people caring for someone who is palliative has been improved. 15 support groups for carers have been established across Perth and Kinross. A carers hub has been established, providing a range of supports, including complementary therapies and telephone support service, and the provision of community-based and care home respite. This strategy has now been reviewed. Local carers and carers groups have been consulted with, and the feedback used, along with information from the updated National Carer Strategy and findings from a recent care inspectorate audit. The 7 outcomes identified in the Joint Carer Strategy 2019 to 22 remain unchanged. The strategy supports the partnership's commitment to enabling adult carers to access support in their communities using universal and specialist carer services, to direct support for themselves and those they care for, and empowering them to be an essential voice in planning and shaping services. The importance of carers accessing a break from their caring role cannot be underestimated, and work will continue to develop services which enable carers to have a break from their caring role. The impact of the cost of living crisis on unpaid carers has compounded the financial impact of taking on a caring role, and throughout the period of the strategy, work will continue to try and reduce financial exclusion of working age carers through promotion of Carers Positive, which helps local employers support members of their workforce who are unpaid carers. The following areas of development have been identified. Firstly, improving awareness of the support available to carers through advertising and community events, more involvement of carers in developing services, to use the strategy to further develop our commissioning arrangements to support carers, supporting carers to find or maintain employment as part of the National Carer Positive Initiative, the rollout of a carers befriending service, enhanced bereavement support for carers and support for people caring for someone who is end of life, services for people caring for someone who's had a stroke or dementia, improve the process for carers to access services, and to work with third sector colleagues to improve the range of respite options for carers. Happy to take questions.
Thanks so much, Kenny. There's a lot of good stuff in this paper. Questions, please, for Kenny.
Quick one, Kenny, thanks. In the page 15, you give a commitment on young carer statements in the weeks to deal with their requests, and the same for adult support plans. I was wondering, what is the current time or the length of wait on these services?
Sorry, the proposed timescales are in the paper. You mean the actual times that are taken at the moment? Karen, do you have that information?
For example, when it comes to terminal illness, to have the conversation within 5 days and to have the actual support plan, unless dictated otherwise by the carer, we haven't breached that at all. But in general, if it's the social work intervention or the carers hub, there are waiting lists. I don't have that data to be able to share with you today, but in general, we are meeting our timelines. As I say, we also take into account the circumstance of the carers and how we prioritise that individual to work with the carer to have the outcomes identified and then look at how that delivery would be met. I don't, as I say, have the data in relation to if there's any across the board breach.
Thanks for that. It doesn't really answer the question. What I'm trying to do here is to find out not what the potential plan is, I don't disagree with it, but what are we faced with now to get to there, and how that relates to establishing this report, not just nice words, but actually getting done on the ground. And how can you review the timelines about needs, and you don't know, even now you don't know what the waiting times are?
Ian, sorry, if you leave that one with us, we should be able to get the timelines from our database, so we will get back to you.
Yeah, okay, thanks.
Okay, Bernie Campbell.
Hi, I really only wanted to make a comment to the fact that myself as one of the public partners.
You've switched off, Bernie.
Sorry, I don't know how much you heard. So it was really just to say that myself as the public partner and some of our colleagues within Carers Voice have been fully involved in the development of the carer strategy, and we have worked alongside Karen and her team, and I think it is fair to say that possibly certainly in the last 6 months or so we have seen some really positive outcomes for unpaid carers, and it is not easy, and there's certainly challenges that come up now and then. But I do think that things have progressed considerably from maybe, a year or so ago. On Ian's point with regard to a carer's assessment, I can only make a comment, Ian, that certainly I was involved with an unpaid carer, and that's a few weeks ago, and they didn't have a carer's assessment, and certainly they needed all of those things in place. But I can tell you it was picked up and it was actioned really very quickly. I don't know if that's the norm, but that was my experience of just a very short time ago. Thanks.
Sheila McCall.
Thank you. First of all, good report. Thank you for that. My question really is on, paragraph 10.2, working in partnership. And I think that one of the things I'd quite like to understand is very often when I get approached by constituents about needing support, what they really, and I've directed them towards the Carers Hub, they come back and say, but that doesn't really give me the support that I need. The support I need is for the services for the person I'm caring for to be in place. So I'm just wondering, and so I think the people who access the Carers Hub, the carers who do access that, it's what they need. But there's perhaps a whole cohort of carers who, for them, this isn't really what they need, and it's to do with a deficiency in service provision for the person they care for. So I'm just wondering, how do we square that circle, or circle that square, or whatever, and make sure that we get the appropriate feedback? Because I do know, like I said, from my own postbag, there are a lot of people who just think this is not for me. I wish they'd spend the money doing this for this service. So it's that gap. How do we get that gap filled?
I suppose good communication is part of the answer to that one. If people are going to the Carers Hub and the Carers Hub are helping as far as they can to support the carer themselves, and they then have questions about the services for the person they're caring for, the Hub should be able to give them information on how then to access that. I mean, most of the people who are caring for somebody receiving certainly services from the statutory sector should have a contact person in those relevant services that they can contact.
Thanks, Kenny. I know what they should have, but I also know the reality is that very often people don't. They don't have a named social worker, or sometimes they've not had a proper assessment done for some time regarding their needs. It's the person who's been cared for, and sometimes they're told, quite frankly, we can't afford any more. So there is gaps there, and I think if we do want to address the needs of carers, we have to acknowledge that those gaps are there. So when we're developing our wider strategies for the Health and Social Care Partnership, that we take that on board. My worry is that these carers are falling through the gaps because they look at what the service has been offered and think that's not for me, that's not where I need the support. So, you know, I think I would like to see some acknowledgement of that. I know it's not an easy fix, and I know the pressures on both resources, you know, in terms of staffing and in terms of budgets. But I think we need to acknowledge that it exists and find some way to at least start addressing some of those issues as we go forward.
Yeah, certainly note your comments. I think the point I was trying to make was if people are going to the actual carers hub, the carers hub then knows where to direct people to. But as you say, lots of people do know where to go and there are still issues. I mean, certainly we do try and be as flexible as possible. We do operate eligibility criteria. We do find out the right resources. But yeah, there's always more that can be done. Yeah.
Thanks. I just wanted to thanks Councillor McCall for raising that issue, and in terms of the progress reporting around the carer strategy, it may be that what we want to do is actually quantify and qualify some of that in the reporting back, because there are gaps in terms of people's experiences, whether that's support for carers or for the cared for person. We need to acknowledge that. So I think we'll take away some thinking around how we might report on that and quantify that for future reporting. Thank you.
Thanks, Jackie. Martin Black.
Thank you. Just under number 4 on the next steps, and it's the second one down, more involvement. I would be saying more involvement and support of carers and development services. And because the carer may not have the confidence, may not have the knowledge, and to work with the carer to articulate what they need to move forward and help to develop service.
Yeah, I mean, that's a very good point. In the report, it does say, you know, the number of carers that we're supporting, I think, was 3,000. But the number of carers for people reporting themselves as carers in the last census was significantly more than that. So, you know, there are lots and lots of carers out there that we aren't supporting at the moment. And it is a case of actually making sure that, you know, we are advertising how to access support for the carers. We have done a lot. There's information available in a range of formats, as we said. We are looking at trying to improve that, looking at, for example, the bus stop outside, you know, the wee electronic signs up there, getting information on carer support on the signs, possibly looking at television, radio adverts as well. We already use social media. It's just linking in with our comms teams and just enhancing that use of social media. So yeah, it's just getting out there and getting the message out there that the supports are available, because, like I say, the majority of people reporting as carers in the last census, we aren't actively supporting at the moment. Sorry, Karen would like to come in.
Thank you. I also think you make a valid point in relation to the investment in carers to be confident, and certainly our Carers Voice group, and who are also equal partners on our carer strategy, very much will actually train and support that confidence and actually align the Carers Voice representative, and I'm sure Maureen absolutely knows all about this, and they will look at what is happening in that carer's life or lived experience and then match that with their contribution. But I think as well within the document we invested in a learning development officer, and that was also about the investment in carers and their learning and what they also have involved in their caring role, but also to become a champion and be able to lead as in voice, advocate and influence. So I think that's a valid point, and the next 3 years we've already got the investment to keep that journey going forward.
Maureen Summers.
Yes, I would just like to say that I first became a carer, an unpaid carer, about 30 odd years ago, and things have definitely improved. One of the most important things is that the carer is identified at the time of the cared for person becoming, you know, in need of help, and they should be offered, you know, or pointed in the direction of a peer support group, because I was totally on my own for the first few years and don't know how I've survived really. Like, it's a terrible memory to think about. And you think you're the only person in the world that's doing what you're doing until you get directed to a peer support group and find out that there are other people who totally understand where you're coming from. I mean, even family members will say, oh, I know what you're going through, but they don't really until they've walked that path, like, you know. So it's really important that that's promoted as much as possible. You know, the peer support groups that are available out there for the different caring backgrounds. There's dementia peer support, there's mental health peer support, and you know, there's for the various physical disabilities too, and learning disabilities. So that's really important that people get directed to that right away, and the frontline staff should be made aware of that. So nobody told me. I just picked up a leaflet at the hospital by chance while I was waiting to be seen, and that put me in touch with a group that really helped. So I think that's, you know, one of the most important things. And the other thing is they talk about identifying unpaid carers. But if they identified all the unpaid carers that are out there, they wouldn't be able to, you know, well, they could maybe give them an assessment, but they wouldn't be able to, you know, give them what they're maybe thinking would help them, because there just isn't the money there for it, you know. There'll never be enough money, you know, for the support that's actually needed. But there's thousands of unpaid carers still out there, like, you know, that need help and support. But you know, I'm afraid that if they were identified, there probably wouldn't be enough money, you know, to give them an assessment and, you know, say to them what would help you, and what would help probably they probably couldn't. It's like raising expectations that they can't fulfill. So.
And just to say thank you, Maureen, for telling us about your experience, and also acknowledging that things are a lot better than what they were 30 years ago. We've had a lot of people with lots of experience around claiming a lot of experience, so, but around the table today. But thank you for that. I just wanted to say, Kenny in his introduction indicated that having a further 3-year strategy allows us to look at how we're contracting and commissioning services, and that may allow us to increase the level of support by commissioning in a different way in order to meet this strategy. So that's something that we will commit to do over the next 3 years.
Thanks, Jackie.
Maureen, totally agree. And as a fellow strategic partner, we have discussed this at length at our strategy group. You're absolutely right. And befriending and peer support, we know has been captured for the next 3 years journey. I think you're right about getting in the right place at the right pace for the carers, because we don't want to have the unpaid carer going into crisis. And we do know that from 2018, just before we launched the strategy, that carers, that people, loved ones being admitted, for example, into permanent care due to carer breakdown. So we're already getting to the journey point too late. In 2018, it was at 70% of carers going into crisis and people then being admitted into permanent care. And we reduced that to 36%. And the last data that we looked at, that has decreased to 16% in December 2022. But I think you're right, we don't always get into the right place at the right time. And I think you also put a respectful nod into where we also need frontline. For example, we invested through our learning disability scope team and unpaid carer support. So they are already in that engaging. We have increased our hospital carer support workers to be moving across all hospital sites, because we recognise in year 2 of the strategy that we were still getting ahead of that. So I think you're right about where we put our workforce to engage and the importance of developing up that relationship, but absolutely getting ahead of that crisis. I don't disagree, and absolutely it will be part of the journey going forward.
I would also like to agree with what Sheila said too, because she said it's not so much what the carer wants for themselves, it's for the person that they care for. If you get that right, then the carer's 100% happy, like, you know. It's not all about, you know, what they need for themselves, it's what the cared for person needs to go on. So I agree with what you say.
And also, Maureen, we also invest in replacement care. But you're right, there are challenges there. And we did put forward investment area from our gap analysis too. But like so many areas, recruitment was difficult and things like that. So again, we will continue that through for the next 3 years.
I'd like to ask you a question, if I may. I'm really taken by the palliative care offer that's in the paper. Independent advocacy feels as though it's part of that, but to help people get through the morass of health and social care system, housing benefits, social security benefits, for example. Do we have the same priority for complex care cases, which have an equal priority for us here? Is there different funding models for those, that because it seems equally as important there too? And I know that this was a recent important issue for carers when they were looking at palliative care, but I guess it's across the board.
Yes, I mean, obviously palliative, especially end-of-life care, is a priority for obvious reasons in terms of timescales. But yeah, in terms of people caring for somebody with complex needs, certainly if they've got a learning disability and/or autism, we do have a dedicated carer in our scope team, the multidisciplinary team to support people with learning disability and autism. So yeah, there's dedicated ring-fenced resource for that client group.
Okay, thank you. I think I'm going to move now to the recommendations. And it's recommended IJB approves the revised joint carer strategy and requests an update in 12 months' time on the implementation of the strategy. Do we concur? Oh, sorry, Colin, I didn't see you.
Thanks. I wonder whether we also need to issue the direction as set out in Appendix 5.
Yes, that should be on the cover paper. Yeah. I think we'll be hearing a lot more about directions in due course, don't you, Jackie? Thank you very much indeed, and thank you so much, Karen, for joining us today. Excellent. It's a very good paper. And just to finish, Maureen, I think the more evidence we get around what the real need is out there is really important, because unless we identify the need, we won't get the money. So it's a chicken and egg thing, I know, but it's the best way. Okay, then, thank you so much then. I'd like to just go for information now, reporting forward plan of 2023-24. This is a copy just here for your information. And we have the, sorry.
Thanks, Chair. It was just a couple of comments on this. The Tayside Winter Planning Report, or Winter Plan for 23-24 is due in November. I think we'd previously had discussion about whether actually drafts of that should be provided earlier for input, because by the time it gets to the end of November, it's a bit late if there's something else that the board wants to see in it. And I was just checking back previous ones. I noticed that we were due to have a review of inpatient rehabilitation beds at our last meeting, but that seems to have dropped off the forward planner, and I wondered if that was something that was still required and if it could go back on at the appropriate point. Thanks.
Thank you. In terms of the review of rehabilitation beds, that's something that we're taking forward as a major area of transformation, and are about to receive a report in terms of what that will look like. I think tomorrow, Chris, would that be right? So it's something that's still under a work in progress, I think, is what I would say at this point in time. I don't think we're ready to bring that forward yet. Councillor Stewart.
Okay, thank you very much. We have the future meeting dates for the IJB and IJB development sessions. Thank you so much, and I now close the meeting. Thank you.